This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
So I know we're running a little late, so I'll skip all the niceties and get on with it. Yeah. So we do dying badly, we know that, and we're all worried about it. We wouldn't be here. Patient-centred care or person-centred care improves outcomes at end of life. And I think it's pretty clear, and it improves it for patients, families, practitioners, hospitals, everyone. Yet we continue to harm vast numbers of patients by not asking them what they want and giving them unwanted and unhelpful interventions. So we at University Hospital Geelong thought, can we do better? Can we improve patient-centred care? So I'm going to show you in a second a video about communication and what happens if you train a group of ICU registrars and nurses in how to identify patients with a life-limiting illness and communicate with them. So in terms of identification, there's a lot of people talk about this. We actually didn't want to predict who's going to die in the short term. We just wanted to turn off the screen. And which is good. I actually didn't have a talk. So what we wanted to do was find patients who had a trajectory of illness that was approaching death in the next year. So not so much is the acute thing that's happened to them that is the cause of their MET going to predict their death, but where are they headed? And there are some really good community-based palliative care tools. We thought we would use the gold standard framework tools. It's a UK palliative care model, and they have that 50-50 question, but they've also got specific clinical indicators, and we used them. So the specific clinical indicators try to identify three groups of patients: those with sort of frailty-related diagnoses, those with metastatic or untreated cancer, untreatable cancer, and organ failures. And so we applied all three of those to the 1,000 patients referred to the ICU to see, are they actually useful triggers? Hopefully, eventually, you'll see a picture which shows a figure that probably about half to two-thirds of patients referred to our ICU over a 6-month period as METs or direct referrals had a life-limiting illness. The mortality of patients with a life-limiting illness was very clearly followed their trajectory. So if they didn't have a life-limiting illness, they had a 1-year 7% mortality because we linked them all to the National Death Index. If they had organ failures, they had about a sort of 30% 1-year mortality, which you might not say is that high. And in retrospect, we're a bit liberal with how we use that. If they had a frailty-related diagnosis, they had a 50% 1-year mortality. And if they had the cancer diagnosis, they had a 70% 1-year mortality. And if you look at this sort of Kaplan-Meier survival curves, it's really clear that having a life-limiting illness and using these community-based, very easy-to-use triggers identifies patients. You with me without the slides? It all makes sense? The video is going to be hard. I'm going to have to act it myself. But I like attention, so it should be good. So we also, when we looked at those patients, we sought to see if they had any treatment limitations, discuss goals of care forms, and probably, I've got the numbers here in front of me, only less than half of these patients had a goals of care form. Only about 10% of them had an advanced care plan. So these are patients who will, 50% chance of dying in the next year, and that's despite us having a really mature, good, respecting patient choices, community-based program. So we're probably just not catching them. When I say 50% had a goals of care form, I don't think we should ever mistake having a goals of care form filled out as being the same as having patient-centred care, because, as hopefully I'll show you a bit later, you can easily tick the boxes without ever having asked a patient about what matters to them. I think that's what happens a lot. So knowing all that, knowing that we're doing really badly as an institution, that less than half of these patients who are going to be dead in a year had a goals of care form filled out while they're in hospital, we designed a program called iValidate, which is about identifying values and listening to patients at sort of high risk of dying, supported by our board and our executive. And our goal was to improve patient-centred care. We got everyone together, all the palliative care, us, communication, ethics experts, education people, and created this 2-day training, interactive, small group voila, training program based on the Cambridge-Calgary system. We redesigned the sort of process of care, which you may not be able to see, but we said to them they had to follow these steps, identify patients with a life-limiting illness, which is easy to do using that sort of GSF stuff, establish their competence, and if they're not competent, find a surrogate, identify their goals and values, and a lot of the communication training goes towards that. Then give appropriate medical advice, try and get consensus with them about a plan, document it all, then hopefully follow them up. And the last step, which one day we'll get to, is bereavement support. And we ran our first course in last year. Now hopefully you'll get 6 minutes and 24 seconds of video.
The traditional role of the doctor is to treat, to cure, and to prolong life. But this is not always in the patient's best interest. Too often, people receive treatments that may be unhelpful and unwanted, particularly when they're coming to the end of their lives. Conversations regarding end-of-life care and choices can be confronting for any doctor.
They're difficult, challenging, it can be quite awkward, and confronting not only to the patients but also for ourselves and for the family.
You know, everyone tries their best to do these things, but it's often uncomfortable when you talk with patients about what they wouldn't want to have when it comes to end-of-life care, and I think it's something that I'd definitely like to learn more about.
I find it much easier to discuss treatment options and provide treatment regimens, but it's a really difficult concept to withhold treatment and to have those discussions with the patients.
Treatment decisions are being made in hospitals all the time. However, if patients are not fully engaged and included in these decisions, they will risk receiving treatments they wouldn't want. Although these conversations may be confronting, they are extremely important.
There is this mysterious veil around the ICU, and patients' family coming and expect we are able to cure them, keep them alive indefinitely, and oftentimes there's a lot of therapy that is futile and we would not offer it to them. So I find that managing the patient's family expectations is actually quite tricky and challenging. Yeah.
I think it's something that is not only hard for junior doctors, but I think it's hard for senior doctors as well. I think it's hard across the board.
Although doctors may feel apprehensive about this type of conversation, it is so important that these discussions are raised sensitively and honestly, so that doctors will be able to understand patients' views and values, hear their stories, and truly know their wishes. The iValidate course has been specifically designed to assist doctors to become comfortable and confident to have these conversations. The course works from a patient-centred model, encouraging doctors to work with them to help navigate treatment pathways together, while acknowledging that each doctor is unique, so will develop their own approach and style. This course offers a structured framework that is based on advice from experienced clinicians, with steps broken into manageable areas, including initiating the conversation, information gathering, shared decision making, and concluding the conversation well.
Everyone has varying levels of comfort with role play, but for the purposes of today, I just want you to think of it as an opportunity to practice and try and just put yourself in the position of having this conversation as a clinician, as you would do on the ward.
Simulated roleplay offers participants the opportunity to rehearse these conversations in a supportive environment where they are given constructive advice and guidance.
So you got to do quite a few summaries. Did they feel okay?
It was really good to practice with simulated patients and just sort of trial different ways of approaching this sort of situation.
If you're able to run through it a few times, you get a feel for how you want to approach these things.
It's quite nice to know that the different people from different areas of the hospital have the same issues, and we've all come together and worked together to find a framework which works for all of us.
What I reckon is going to be helpful for you now is actually getting the rest of the group to wordsmith. So your strengths are that you are a good active listener and rapport is easy for you.
Without a doubt, I started using it pretty much straight away. There's a big difference in my ability to just even approach a conversation with a patient and how to structure it and get a good outcome for both the patient and for the teams involved in care. Patients often feel relieved when you do bring it up and discuss it and family as well often feel uncertain about bringing it up with their loved ones. What I'd like to start with is talking a little bit about you and how you are at home and what are things that are important to you in your life. If you could tell me a little bit about yourself.
Yes, well, I live alone now. Children have grown up. I've also had a very active life.
I've always thought that it was really important to have good skills around communication and talking with families and patients when they're really scared of what's happening to them and what the future might hold. And a lot of them know that they're really unwell and their end's not far away. It's a reality of life. And I think the course has allowed me to specifically hone some skills and learn some skills that help me negotiate some more challenging conversations sometimes, but also be more proactive in reaching out and having those conversations.
Really want to thank you for having this chat with me. I'm feeling comfortable that you're talking to me about this.
How did your structure tool go?
I think it went okay.
How did you go with the rest of the conversation then?
The summarising allowed her to kind of...
I feel a lot more confident and comfortable doing so. I think the iValidate program has provided a good set of tools to be able to use going forward, and it gives me a lot more confidence now.
I feel like I'm more confident and I have a way to approach it, yes, and certainly the simulated learning helped with that.
iValidate course had really given me a good structure on how to approach these issues, and when I do get nervous, I go back to the structure step by step.
Patients have a right to know what's going on and should be supported to make the decision that is right for them. The doctor's role is not only to treat, but also to offer comfort and support in end-of-life care.
So I know you all cringe when someone used the word futile and withhold care. That was the before bit. I was thinking of cutting it out, but I guess it was there, so we should leave it. So what happens when you train a cohort of ICU doctors and liaison nurses? We did a before and after study, the two-month periods, and the goals of care documentation improved from 50% to 72%. Still not what we want. We want sort of over 80%. This is within 48 hours of referral. These patients are referred quickly, so about 60 to 70% of them are referred within 48 hours of admission. So if we're going to do this, it has to happen fairly early in the course. In terms of the patient-centred component of this, it's still pretty low. It went from 16 to 32%, which is really significant, but it's still low. To give you an indication, when we audited the medical wards, only 5% of patients have got any reference to their values being identified. So I suspect this is done badly in a lot of places, but we're getting there. We're better at giving advice, and we love listening to our own voices. Interesting, it's a small cohort, but those who did have advanced care plans, we went from 68% concordance to 100% concordance. That's something. There were effects on what happened to those patients. Again, it's a small pilot, single-centre study, but the incidence of MET calls went down. And the other results are non-significant but important in that their access to the unit didn't go down. More got admitted, their hospital mortality went down, their 90-day mortality went down. So one of these criticisms that the intention of having this type of goals of care discussion with patients who are at high risk of dying is that we just want to exclude them from ICU and that they're all going to die. That's clearly not true. They're coming in. And this is you'll be pleased to know, the last slide, I think second last slide, cancer. We just looked at some of the trajectories. I didn't put the organ failure trajectory up because it doesn't quite tell the same story, but if you look at cancer and the frailty groups, they have very different results of the iValidate program. So the cancer group ended up with a lot more of them going home, but then getting readmitted with a reduction in their 90-day mortality, which I guess isn't that surprising for a group who are very well and are suddenly declining. It would appear to be that's what they want. The frailty group, who are dementia, stroke, nursing home patients, we reduced their med incidence. Not many go home, only 20% go home, but their mortality didn't change, but their 90-day readmission reduced. And maybe that is what they want and their families want, and what we want is a group of patients we can't actually help to have them out of the acute hospital and into subacute care. So again, you know, I'll preface this with this is small numbers, single centre study, but that's encouraging. What next? We've just changed a whole lot of ICU, Gen Med, ED regs, where in July, August we're going to try and capture all the regs we missed, do the ICU senior nurses to try to make a more complete system in the ICU. We've got physicians, ED consultants, ICU consultants coming to do the course. They're interested. We've got some of the exec who say they want to do it, which should be interesting. And we're getting requests from other units, orthopaedics, peri-op, gynae, surgery, to say can they do it. At the moment we're sort of trying to budget to train 80 to 100 doctors and nurses a year. It's funded by the hospital. We'll see. Our goal is still over 80% of patients with a life-limiting illness have their values identified within 48 hours of admission, which really is a culture change issue for the hospital. And that's it.